And next one is Edentulism maxilla. And then there's one is under single tooth, and another one is partial. But you take out the subheadings, then when you read them by itself, it doesn't really make sense. And in fact, in some areas, it may even be conflicting with the other guidelines, the other recommendations. So this is a consequence of sometimes staring at the same thing over and over again and missing the forest for the trees. But eventually, after the consultation and peer review process, it goes to publication and dissemination. And then the next stage is implementation. In our write-up for this AMS MOH clinical practice guideline, there's a prioritization exercise. In this prioritization exercise, now because early on I did mention that if you just get a few wise men together, it's a relatively inexpensive option of drafting a guideline. An evidence-based guideline takes a lot more resources, and MOH Health Technology Assessment Branch is Dr. Pri. Dr. Pri is around. So his unit can only support 4 CPGs a year because it's extremely time-consuming. You need well-trained staff to be able to go through the literature, go through the way we draft recommendations and appraise the literature, and so on and so forth. So Dr. Pri will then, every year, will call for a prioritization exercise where different parties will submit topics that is of interest, that we feel is important for the country, and we say, okay, let's do a guideline on this. And so Dr. Pri and his team will then look at all the topics that's submitted and decide which topic should be accorded that priority to form a guideline for that year, right? So we have to prove the burden of disease. So it's got to be something that is widespread and prevalent enough and impact enough people, and there's got to be an existence in the variation of practice. So even if something there's a real burden of the disease to the population, but there's no disagreement among the practitioners, that everybody agree roughly, okay, this is what we're going to do, then is there a need for a guideline? Then there is no need, right? And there's also got to be evidence of effective practice. So a combination of these factors, that yes, there are equivocal practices out there, but then if we were to look into the literature, there must be enough evidence in the literature for us to make some recommendations that's scientifically based, that's evidence-based to the practitioners. If everybody do things in a different way, but there's also no evidence out there to prove that, to lead us into a more evidence-based kind of practice, then it's also not worthwhile having some kind of guideline that is which will be based on a lot of hearsay anyway. And we need some evidence of support from the stakeholders, right? And eventually the implementation of the guideline. And one of the things that Clin should do is also because of the support of CDO in implementation. How that is going to be done is beyond the purview of my work group. We are purely the clinical, we do the clinical work, scientific work. The implementation will be up to MOH, how they're going to make use of these guidelines in terms of implementation. That will come in a later, in the months to come. Right. So this is the process that we go through, a proposal. We form the group. We have our first meeting. And actually before the first meeting, we need to attend a workshop. We need to be trained. So we don't just pick with whoever. I don't just pick my friends out and then say, okay, let's sit down and together and work out a guideline. So MOH organizes a workshop, and we get trained and calibrated on how to appraise the literature and how to write these guidelines. Then we have our first meeting, and we sit down and we trash out what kind of key questions that we're going to ask or we're going to address. And even selection of the key questions usually it can be quite contentious. Some people feel that this is an important topic we need to address. Others feel that something else is more important. And there's a limitation as to how much we can address. There may be a lot more issues out there that need to be addressed. But as it is now, this work group has 22 people in there. It's already one of the larger work groups in amongst all the AMS, MOH work groups. And trying to get 22 people in together for a meeting is a logistical nightmare. So we go through the literature, critical appraisal, put up an evidence table, and when that is done, we do a first draft. So we break up into groups, and each group will assess a question, and then after that, each group will present its findings to the entire group, and we will scrutinize and criticize each other's research approach and all that, and we get some responses to the first draft, and then comes the editing. A lot of the editing is done by Dr. Priest's staff. And it's also very tough work for them, because for the work group members, the 22 of us, some are in private practice, some are in institutional practice. We are primarily clinicians, and so his staff got to make sure, got to check the veracity of the statements that we make, and then very often they come back to us and say, you make this particular statement, which is the paper that you're quoting to make this statement. And then we will say, okay, we fish out this paper and we say, okay, this is a paper upon which we base this statement on. And then they'll say, oh, but you make this statement, this paper is only a case series. You cannot make this kind of statement and call it this kind of evidence. And we've got to start shifting again, right? So there's a lot of this toing and froing. And eventually goes to a peer review where we send out to the special societies, institutions, university. And then after that, if we get feedback, we go back to the editorial group, and eventually DMS signs off on it, and then it goes to print, and then here we are today. Right. So, okay, topic selection, I mentioned this earlier on. Composition of the group. It's a multidisciplinary group, so later on I'll show you the list of work group members. Now I'm an oral maxillofacial surgeon, so there's certain bias. I'll be the first to admit that. So when I start picking people, I look at my fellow OMS first, right? And there's always this disagreement between the OMS and the periodontist. The periodontist will have a slightly different slant to their approach to implant surgery compared to the OMS. So it's important that I also bring the periodontist on board. And if we do this under the Association of Oral Maxillofacial Surgeons, then you probably wouldn't have the periodontist on board, right? Then the buy-in from the periodontist will be less. But being a college, we house all 7 specialties in dentistry. So we can draw on the periodontist to work with us as well. So we identify a few periodontists and come on board. And ultimately, patients don't come in for implants, right? Patients come in because they want to have the crowns on top of the implants. So the prosthodontist got to play a major role in this. So we bring in the prosthodontist. But some of the questions that's been asked that's been tossed around over the last few years is that with the increasing popularity of implants, the tendency is for both patient and dentist alike, when the patient comes in, say with a pulpitic tooth, and the temptation is say, okay, why don't we just extract the tooth and put an implant? After all, success rate is high. I'm not saying this simply because CDO is here and he's an endodontist. So we need to look at the evidence. Is it better for us to have to extract the tooth and put an implant? An off-cited statistic to this is that implant success rate nowadays averages about 98 and some papers even say 100%, whereas endo success rate, I don't think they will ever publish 100% or maybe even a 98% success rate. But of course, the definition, when we look into the literature, the definition of success and survival and all that is very, it's always intermingling and it's rather gray. So it's important that we look at the literature and see, is it a justifiable treatment plan to extract a tooth that has pulpitis, irreversible pulpitis, and then replace it with an implant? Or are we still better off keeping the tooth with a root canal treatment and then doing a crown on it, right? The other issue is also, of course, comparing, so my pet peeve is that periodontists now do a lot of implants. So I often remark to my periodontist friends and say, you guys are supposed to be the last bastion for the tooth, no?